Hi everybody, I'm Mako, and I'm going to talk to you guys about my case study analysis, and it's about AP frog leg pelvis rejections. And I have a question: have any of you had a pelvis X-ray before, and how was your experience? Okay. For my introduction, an AP pelvis projection was ordered in November 11, 2017, around 8:27 a.m. The patient is a 16 years old female. She has no history of allergy, her pregnancy is negative, and she has a history of asthma, a vascular necrosis of the bone of hips, and she has a vitamin D deficiency as well. She has a surgical procedure back in 2010 with transcranial Doppler, and in 2006 she had a cholecystectomy laparoscopic. Have you guys heard of it? I never heard of it before. For her signs and symptoms, she complains about her abdominal tightness but normal bowel movements. She has a fever of 101.5 when she was rushed in the ED. She has no vomiting nor diarrhea, no chest pain, no sore throat, and she has an irregular menstrual cycle too, and constipation. She complains about her lower back, right upper arms, and hip pain. She takes oxycodone every 4 to 6 hours for pain. The reason for this exam is to check the status of her vascular necrosis of the bone because of her history before. Her diagnosis was a sickle cell fever and pain as well as vascular necrosis of the bone. For my procedures and projections, first, the requisition was printed in the department. It was stated that the patient is in the lobby in the main department in Children's Medical Center. I went to the lobby, called the patient, and introduced myself and to her parents and checked the armband, and I took them to the x-ray room. I used the hand sanitizer before touching the patients. I asked the patient about the two patient identifier, and I asked her in the room, so it's gonna be in the HIFA. I asked her and the mother if there's a chance of pregnancy. Even though it was a negative pregnancy, I still asked. I asked her if she's wearing a pants that has a medal on it, and she said yes, so I gave her a gown to change. I prepared everything we needed for the exam while the patient is changing in the restroom. She came back to the room and explained everything to her that I'm going to take like 2 pictures of her pelvis. I lowered down the table for her so I could position her in the table. I informed her about, touching and feeling for her bone, and she said she was okay with it. I was telling her everything step by step. The SID that I used is 40 inches. I used the grid because the anatomy was greater than 10 centimeter. I used 70 kbp and 8.96 mass. Do you think that was enough? I've used AEC to know my mass. I instruct her to suspend her reservation. I didn't use any gonadal shielding because it will obstruct the anatomy that we're looking for. According to Martinson, this is the image criteria. The following criteria or guidelines for an optimal frog legs is the sacrum and coccyx needs to be aligned in the pubic epiphysis. Obtura foramina are actually open and uniform in size and shape. The iliac wings supposed to be are symmetrical, and the lesser trochanter right here is supposed to be medially. And according to Martinson, the related position and procedure should be followed to obtain an optimal image is place the patient in the supine position, place the mid-sagittal plane of the body to the midline of the IR, position the ASI as equidistant from the IR, aligning the mid-coronal plane parallel with the IR, and abduct the femoral shaft to a 45-degree angle with a table. For my errors, as you can see, my collimation is very poor. There's too much space on the left side. On the radiograph, I included more than I should have. I almost clipped the right iliac wing because I was not centering the IR. There's a lot of rotation, including as the sacroiliac joint, sacrum, iliac wings, obturator foramina, and lumbar vertebrae. I clip a lot of my right femur body, and the left obturator foramina have a bigger opening than the right one. I included a lot of the L spine as well, which is not supposed to be too much of that. The image marker placement is very poor as well. The pubic symphysis is not aligned in the sacrum at all. So the inferior sacrum is actually not the center of field. So for my correction, in order to correct my image, I will make sure that I'm in the middle of the IR so I could try to collimate as much as possible. I will check for any rotation, palpating the patient, bony, not marked properly. I will make sure that I will tell my patient every step I'm gonna do and position her pretty good. Sometimes it's better to tell them what you're doing so they could straighten out your body for you. Communication is a great key for a great positioning. I will make sure I could choose a better spot for my image marker. Always use a higher kVp and lower MAT to decrease my patient exposure. It is very important if you're using ASC to have a proper centering collimation to get the optimal image. The appropriate EI range for the equipment for radiology department, I've used a Shimatsu, so EI ranged from 200 to 600. My radiograph falls in 186, which is not really on the range. As seen on the radiograph, there's no internal artifacts, but you could see a minor external artifact from her undergarments, which is right here. And for the radiologist impressions, there's no fracture identified within the bones of the pelvis, so there's no fracture. The sacroiliac and the pubic maintain a great ligaments, and there's the hips are conjugated. There's a persistent widening and flattening of the right femoral head right here, which is called coxa magna, and no proximal femoral fracture, and no soft tissue abnormalities at all, and no radiofract foreign body. There's a stable right proximal femoral alveolar necrosis with a coxa magna deformity, which is a very concern about the right side. It has some flattening of the femoral head. It's actually considered normal radiograph appearance of the left hips. The left hip is fine. So for my last one, I'm gonna go ahead and name 10 anatomy. So this is gonna be from the top. It's gonna be the iliac wing. That's gonna be the sacrum, the iliac crest, the ASIS, acetabulum. That's the femoral neck. That's gonna be the lesser trochanter down in here, the obturator foramina, and right here it's gonna be pubic symphysis and the femoral head. And that's about it. Thank you.